Welcome to this explainer. We're skipping the basic intro today and jumping right into the clinical material. We're running an integrative mixed block simulation on high-yield nephrotic syndromes. Our goal here is strictly calibrated for diagnostic precision, making sure you master the exact nuances needed to hit that 270-plus score. Let's get to it.
All right, let's establish our absolute baseline parameters. Before we even think about breaking down specific pathologies, you've got to instantly recognize the classic nephrotic presentation. A defective glomerular filtration barrier leads to massive proteinuria. We're talking strictly greater than 3.5 grams a day. This directly forces hypoalbuminemia, which tanks your plasma oncotic pressure and results in edema. At the exact same time, the liver tries to compensate by ramping up lipoprotein synthesis, which causes hyperlipidemia. And don't forget, the loss of antithrombin 3 in the urine triggers a highly dangerous hypercoagulable state. That's your baseline.
Module 1. Membranous nephropathy. We're isolating the exact underlying mechanism of this condition. It's a primary disease of the podocyte, but the mechanism is incredibly specific. It's driven by circulating IgG autoantibodies that directly target the phospholipase A2 receptor, or PLA2R, located squarely right there on the podocyte.
Now, the absolute crucial point here is memorizing this microscopic triad so you can instantly recognize its footprint on a biopsy report. Under light microscopy, you'll see diffuse capillary and glomerular basement membrane thickening. Move to immunofluorescence, and you get a granular deposition pattern of IgG and C3. But the absolute diagnostic mandate, that's the electron microscopy. You are strictly looking for subepithelial deposits that create that classic spike and dome appearance.
And this brilliantly illustrates exactly what that visual presentation looks like. Just notice that prominent diffuse thickening of the glomerular capillary walls. There's no hypercellularity going on here at all, just this incredibly dense, thickened basement membrane.
So mapping the strict secondary triggers is critical because it absolutely mandates further systemic investigation. If your patient presents with membranous nephropathy, you literally cannot stop at the kidney. You have to investigate the solid organ risk. We are talking about solid tumors like lung, colon, breast, or melanoma. You've got to screen for hepatitis B and C, evaluate for systemic lupus erythematosus, specifically class 5 lupus nephritis, and definitely audit their medication list for NSAIDs or penicillamine.
Let's draw a really hard line right here. Primary versus secondary membranous nephropathy. You've got identical clinical presentations that diverge completely based on these singular systemic variables. Primary is idiopathic, driven by those anti-PLA2R antibodies we just talked about. Secondary, though, mandates exhaustive, age-appropriate cancer and viral hepatitis screening. The entire management shifts from primary immunosuppression over to treating an underlying malignancy or infection.
Module 2. Focal segmental glomerulosclerosis, or FSGS. This is actually the most common cause of idiopathic nephrotic syndrome in adults, particularly in African American populations. We define this by its sclerotic destruction, its scarring that involves only a limited portion of individual glomeruli, that's the segmental part, and only some glomeruli overall within the entire kidney, which is the focal part.
Now contrast this diagnostic matrix with our first module so you can systematically eliminate competitive distractors. With light microscopy, you see that segmental sclerosis. Immunofluorescence, generally negative, which is a big shift from the granular pattern in membranous. And electron microscopy strictly reveals diffuse podocyte foot process effacement. It completely strips away the normal filtration architecture.
Let's look directly at the evidence for a second. Notice the focal scarring pattern isolated right there in the capillary tufts. Those pink hyaline dense areas? That represents the sclerosis disrupting the normal, delicate capillary loops.
You really need to sear these high-yield secondary associations into your memory to decode patient histories fast. If a case mentions HIV infection, intravenous heroin use, sickle cell disease, or massive obesity causing glomerular hyperfiltration, your diagnostic crosshairs need to immediately lock onto FSGS.
This brings us to a crucial variance: standard FSGS versus HIV-associated nephropathy, or HIVN. This distinction is absolutely critical for immediate management. HIVN is a rapidly progressive, collapsing form of FSGS. Unlike standard chronic kidney disease, which usually shrinks the kidneys, HIVN actually presents with large, highly echogenic kidneys on an ultrasound. When you see that, it strictly mandates the immediate initiation of antiretroviral therapy.
Module 3, Minimal Change Disease Kinetics. Let's look at a pathology entirely driven by a massive cytokine surge. Here, T-cell-mediated cytokine release directly damages those podocytes. This completely destroys the polyanion negative charge barrier of the basement membrane. And what does that do? It leads to a highly selective albuminuria, totally unlike the non-selective protein loss you see in the other syndromes.
This EM image is absolute proof. In minimal change disease, the light microscopy is going to look completely normal, hence the name, right? But the effacement here on the electron microscope is undeniable. Those normally distinct foot processes are completely flattened out and fused together.
Listen, this is a hard and fast clinical rule. Do not fall for the trap of ordering a biopsy on a pediatric patient presenting with sudden onset nephrotic syndrome. Empiric corticosteroids are the absolute first-line mandate. A renal biopsy is strictly contraindicated in children unless they become completely steroid-resistant during treatment.
The crucial takeaway here is the variance in age. Pediatric minimal change disease is typically idiopathic and benign, but in adult presentation, that demands an immediate hunt for a hematologic malignancy. Specifically, adult-onset MCD strictly warrants screening for Hodgkin lymphoma. Why? Because the Reed-Sternberg cells produce that massive cytokine storm that triggers the podocyte damage in the first place.
Okay, let's execute the final integration with our master case blueprint. To test this deep integration, we construct a profile featuring an adult patient with massive edema, nephrotic range proteinuria, and hyperlipidemia. Then we introduce a sudden complication, like severe flank pain. That flank pain is your classic indicator of a hypercoagulable state triggering a renal vein thrombosis. But here is the diagnostic trap. We bury a subtle systemic clue right in the history. The physical exam subtly notes the presence of painless cervical lymphadenopathy. If you miss this tiny detail, you will mismanage the patient entirely. You might assume membranous nephropathy because of that renal vein thrombosis association, but this single lymph node changes absolutely everything.
So, applying everything we've mapped out today, based strictly on identifying that masked secondary trigger, what is the exact electron microscopy finding expected on biopsy?
Here is your option matrix. These are exactly the 5 highly competitive, distinct answer choices you'll face. A. Subepithelial deposits with spike and dome appearance. B. Diffuse podocyte foot process effacement. C. Subendothelial immune complex deposition. D. Glomerular basement membrane splitting. Or E. Nodular glomerulosclerosis. Take a second and lock in your diagnosis.
Let's break down the execution blueprint and show exactly why choice B is the only survivor of clinical logic here. That painless lymphadenopathy in an adult dictates a high suspicion for Hodgkin lymphoma. Hodgkin lymphoma triggers adult minimal change disease. Therefore, the EM strictly has to show diffuse podocyte foot process effacement, making choice B correct. Choice A describes membranous nephropathy, which is a phenomenal distractor given the renal vein thrombosis, but it totally ignores the lymph node. Choice C is lupus nephritis, choice D is Alport syndrome, and choice E is diabetic nephropathy. To wrap up this explainer, I want you to analyze your own diagnostic speed. When identical nephrotic presentations mask vastly different, life-threatening systemic triggers, like an underlying lymphoma or a collapsing viral infection, how quickly can you locate the single variable that dictates a patient's survival? Master the mechanisms, respect the strict diagnostic rules, and you will never miss the underlying truth. Thanks for joining me on this explainer, and I'll catch you next time.